Uh, well, thank you, Amy. Excellent. Okay, great. So we'll go ahead and get started. Good morning, Peggy. Thanks for joining. Um, Whoops, you do not want to see my calendar. There we go. Okie doke. So as usual, we've got a few slides and just going to sort of go over what's new, talk about some of the adverse events that have been more well described since we last met, talk about variants, breakthrough infections, and the recent changes to CDC, as well as what's happening on the child vaccine front. So in terms of the vaccines, it's the same three. So I won't go over it, but you all know the three that are out there. The difference is that things are there's been a few changes. FDA continues to track vaccine stability, has updated the shelf life for several. The most recent one was J&J that was set to expire over the last several weeks, and they've extended it from, I believe, 45 to 60 days with a recommendation to check the J&J website for any vaccine that looked like it was about to be outdated because most likely it is still good for use. In a minute, when I'm not talking, I will put the link for that if anybody hasn't seen that yet. Additionally, you all are aware, Pfizer and Moderna have filed for full FDA approval for 12 and over. Review process is underway. And as of yesterday, from what we heard from Dr. Shah, we're hearing that we anticipate a decision by FDA on Pfizer by early September, possibly even the first week of September. And then, as with other things, Moderna is likely to follow about 6 weeks later. So we are all eagerly awaiting that. Certainly want the FDA to complete their full process. There's also been a lot of discussion about the use of a third vaccine for immunosuppressed patients. The Advisory Council on Immunization Practices, or ACIP, is meeting later this week to consider that, and we anticipate there may well be a recommendation after that meeting. So we're looking for that as well. I'm guessing that many of you get the same questions that we do frequently about what about this patient, what about that patient? I've checked their antibody levels, it's not good. Shouldn't I be giving them a booster? And just as a reminder, off-label use, so it is not under the emergency use authorization, there's not approval, so off-label use is really not a thing right now, and we should all be sticking to the recommendations under the EUA only, but we can get into that more in just a minute. And then Pfizer and Moderna have expanded their trials for 5 to 11-year-olds, and they have filed for FDA emergency use authorization as well for children. We're hoping by year end. I know there had been some talk earlier by the fall. That seems less likely now, but we're very eager to see that happen as well. And as always, folks, feel free to either unmute or put questions in the chat as we go. In terms of adverse effects, I think by the time we had our last, I forget when we had our last one of these calls, maybe June, I don't know that we had July, but there were some cases of myocarditis pericarditis that had been reported in young people. Certainly been more of that by now. Still remains relatively rare compared to the number of vaccines given, but well over 1,000, probably, I don't know, more than that now. But clearly the CDC has weighed in on this and said the benefits still outweigh. Most of the cases have been mild and self-limited, controlled with over-the-counter medications. And so the recommendation is certainly still as strongly to provide the vaccine in young people. But as always, any cases of adverse effects should be reported through the VAERS system. Just a reminder on that, whether you gave the vaccine or not, providers are encouraged to use the VAERS system for any suspected adverse event after a vaccine. And then there's the variants. So Steve, I'm going to pass it over to you.
Thank you. And I was just going to say one thing about the third dose. I always want to remind people that measuring antibodies is only half the immune system. And we know that these vaccines induce a robust T cell response. And there's actually a lot of good data out there on the flip side of why third doses may not be as necessary as we think. So it'll be interesting to see how the ACIP actually figures out how to respond to this question, but they're doing it. I think variants are what's on everybody's mind. Why are they on our mind? Well, because variants are kind of the state of the world when it comes to SARS-CoV-2. Just remember that this is an RNA virus. It does have mutations over time. It has multiple mutations. Most of those don't actually help the virus and do not go on to become a more dominant strain. But we've been dealing with this for a long time. If you remember, the first one that we really were talking a lot about was the UK variant, which now is what we consider to be the standard, the state of the affairs, and we're concerned about the Delta variant. We also remember there was Brazilian variant and there was South African variant, and one of the things we quickly realized is that the nomenclature was really pretty challenging for people. So originally we were naming variants by location, which really probably was not an effective strategy. Then there were numbers. There was B1.1.117.2 and things like that. That didn't work for most people. So now we're using Greek letters. And so the alpha variant is actually what we used to know as the UK variant. And if you then you can look at beta and I'll go on, but Delta is the fourth major variant, and that was the one that probably arose during the Indian massive pandemic, sort of that we saw the terrible effects of the virus in India about 2 months ago or thereabouts. And that has now spread pretty much all over the world. There's been some places where there have been very significant outbreaks of Delta, UK being one place, and there's a few others. And that helps us actually learn about what might be going on here. But here, we do have Delta, and when I say here, that's the United States. It's probably about 80% of all viral infections now, and probably about 70% or thereabouts in Maine. What do we do? How do we measure that, or how do we know? We do have a partnership with Jackson Laboratory, as well as a lot of the commercial labs are doing genetic analysis. The best way to do that is to do what's called whole genome sequencing, and that gives you an idea of the mutant genes and what the virus kind of looks like. And that's usually put out on the CDC website once a week, typically on the work's done on Friday, so it probably comes around on Monday on the website overall. Last time we looked, it was 60%. We still aren't doing enough variant analysis and are trying to increase that and trying to get significant geographic spread. But I think all of us, whether we have seen the data that says the Delta is increasing in Maine, we know that COVID is increasing in Maine, and both the numbers of cases per day as well as the positivity rate have been going up. And if you look to the early July, so I think it's the week of the 1st of July, our positivity rate was 0.4. Our positivity rates yesterday was 2.7. And we were seeing 10 to 20 cases a day early July, and we're now at the 150 to 160 number of cases per day. One of the things we know about the Delta variant specifically is it appears to have a much shorter incubation. We used to think of the virus as having an incubation of 5 to 7 days, and that's when we were often testing after exposure. This is more in the 2 to 3 day range, and it goes from 0 to 60 very fast with very high viral loads. If you're measuring that in a laboratory for PCR, that's actually a very low CT value. And the one thing we have also learned is, although the vaccines continue to be very effective, there have been some breakthroughs. And when viruses infect and have infection in vaccinated people, they also have high viral loads. But I think it's important to look at the the big picture and sort of say, are the vaccines working? And the answer to that is yes, they are. We know that they were not 100% to start with. We knew that there were going to be some percentage of individuals who did not respond or did not respond appropriately, effectively. And even when we see breakthrough infections, we see that most of the people have mild symptoms. It keeps people away from severe disease and out of the hospitalization. And that's not 100%. There was the outbreak I think everybody heard about, which was in Provincetown, that was written up in the MMWR, that looked at a pretty big outbreak in Provincetown, Massachusetts. I would only have people recall that was the 4th of July from hell, where instead of everybody being outside and having outdoor activities, they were all indoors because it was terrible weather. And there was but very large crowds in indoor spaces with, although a majority vaccinated, some not vaccinated, and transmission occurred. So we are learning more as we go. But having said that, vaccines remain effective in preventing severe disease, hospitalization, and death. If you look at around the country, most of the deaths, 99% and probably 90% of infections, are due to the unvaccinated. In Maine, we're fortunate in that we've had very high vaccine uptake, but remember, in places like Texas, Florida, Louisiana, where the pandemic is raging, they were in the 30 to 40% range. I know, for instance, in New Orleans right now, their hospitals are full, and they're full almost exclusively with COVID cases. And so this is an incredibly serious point in time for the pandemic, and especially in those places without high vaccination rates. The concern we have not only for the individual in this situation, but it is the more replication we see, the more potential for future variants there is. So that's one of the concerns. And there is an epsilon and there is a lambda that are out there that are of some concern, that are being watched. The CDC, because of not just the Provincetown outbreak, but data that they saw, changed their masking recommendations. I think most people are getting a little more comfortable with what the recommendations were based on, but it was pretty confusing early on. And I think everybody was kind of scratching their head going, okay, what are we really trying to say? Well, we're saying that if you are in an environment where the risk of community transmission is significant, or in their terms is substantial or high, then you really should consider wearing masks in indoor spaces. How do you find that data? It's really the best place is on the governor's website. It appears to change relatively frequently, and that's because it does. And that's because it's a 7-day rolling average determined on a daily basis. And therefore, and if you're a place like Maine where we do not have huge numbers, the possibility that one of these counties could flip back and forth is certainly possible. And we did see that. These are the 1, 2, 3, 4, 5, 6, 7 counties that presently are considered to have substantial transmission. Waldo is the one that is considered to be high transmission at the moment. And I would encourage people just to get into the habit of looking at this. But on the other hand, I think, this is my opinion now, not the US CDC guidance, is as we move towards the fall, if the Delta is continuing to be highly prevalent, which I suspect it is, and we start moving indoors more, you may recall we had a pretty big surge going into the fall before. And so we may begin to start seeing masking as sort of routine for indoor spaces with crowds overall. It's really the same guidance, which is the masks are to both stop transmission as well as to help an individual overall. The contacts and the distances have not changed. Some people have asked if that's going to happen. I don't know. I think that's being looked at because this does appear to be, again, a significant level more contagious overall. But the important thing is that vaccinated people can get it. They tend to still be overall protected. This is a problem predominantly of the unvaccinated, but in a large crowd, and I saw a picture of a concert in Maine, in Bangor the other day, which was like a very large crowd with a large number of non-masked people. I do not know their vaccine status. I do think we are putting ourselves at risk again in those situations. And I think that's about all what's next here? Yeah, I think this is the same information. And
Right.
I think
Right.
that what I really want to do is sort of get to people's questions because, as I said, this went a long way to confuse people for when it was first came out, and we're still fairly new with this new nomenclature and new direction.
Yeah, so then Amy was going to say just a few things. Maybe
Yep.
go quickly through the child vaccination stuff, Amy, and then we'll take questions.
Yep. So as we get ready for school to start again, and some have already started up north, there is vaccine data by age on the website. Zip code level data is available, and you can parse it out by 12 to 15 and 16 to 19-year-old, also by county. They will start to report vaccination rates by school administrative units mid-August. They're working through the process right now on that, and that will also be linked on the DOE website as well as the website you were just looking at. And go to the next one. We're also asking schools to start reporting school staff vaccination rates in September, and this will also be publicly posted be similar to the Maine healthcare worker COVID-19 vaccination dashboard. Let me go to the next slide. So we're asking the health systems and vaccine partners to work with the schools. There is a link that schools can request help hosting a COVID-19 vaccine clinic. So, schools can host them themselves with the school nurses. They may be working with a healthcare partner already, or if they don't know who to partner with in their area, they can apply through this link, and the immunizations program will match them up with a vaccine provider. We have heard from some of the schools, they're interested, but they're not quite ready to do it because they're getting prepared back for school. Some of the vaccine partners have said that's fine. They'll go in and host community clinics for them. So we're just trying to connect people together and really try to have a push towards getting COVID vaccine in the schools as soon as we can. We're about 50% of children between ages of 12 and 19 who are able to be vaccinated or vaccinated at this point. But there's quite a variation. There are a lot of schools that are over 50% vaccinated for students in 12 to 19, but there's a large group that are under 50%. So our goal is really to target those that have vaccine rates under 50%. Go to the next slide. There was a letter from the immunizations program sent out to all the Maine immunizations program providers. This was more due with the new state law that goes into effect September 1st, LD 798, but it also is encouraging providers to work with families on COVID vaccine. They're also going to host a webinar on Thursday with vaccine providers around providing both COVID and flu clinics, and they sent that out to folks.
Sorry, I didn't mean to. I was trying to highlight something on the slide. Sorry, I didn't mean to cut that off, Amy. Is there anything else? Sorry, no, really goofed up here. Or anything else there?
Nope. I think the big thing is the health systems and vaccinators did a great job in the spring, and we are just trying to do another push as the fall starts again. And we know that potentially the 5 to 12-year-olds will get authorized sometime in the fall, early winter.
All right, so questions. I'm going to stop sharing so we can see if there are any chat. Questions, comments, as you guys are encountering, need more information on. Not seeing anything in the chat. Wow, quiet group. I see a couple of our clinicians who've been on our advisory group. Jim, Peggy, anything that you guys are encountering in your travels that you want to highlight the group or questions you're getting?
Lisa, most of the questions I've been getting have been around masking in schools about that more than anything else of late. And then obviously we've been having a lot of questions about, the health systems that are now going to, and hospitals that are going to now require vaccination and similar concerns that we hear out in the community. We hear from our own employees and staff. So.
Yeah, thank you for that. So folks have probably seen last week both Northern Light and Maine Health, and interestingly, Millinocket Hospital before that, announcing that they're going to require staff to get vaccinated either as of a certain date, or in the case of a couple, Northern Light, I think it was within 6 weeks after full approval. Jim, is that right?
That is correct.
Okay, seeing one question, where's the uptake in vaccinations happening now? Any focused areas are generally across the state? Yeah, so that was reported yesterday, I think a 12% increase in vaccinations. I'm not sure over what time period exactly. I don't know, Steve, have you? I haven't
Yeah,
seen
I'm
more
not sure.
specific data.
Most of the data I've seen, I think that what's been happening is that it's been a steady number of approximately, this would be probably about up to a week ago, 1,000 a day. And it was fairly well distributed overall. I don't know what that statistic was specifically referring to, so I can't answer on the 12% for over what the period of time was. But there's, if you look at the nation, there's been a very sharp uptick in vaccination in areas that were less vaccinated, but still not enough to get us to a place that we'd like to be. So I can't answer that completely.
We did hit the other very nice benchmark yesterday, right? Maine among 6 states that have 80% of adults 18 and older who are vaccinated. So that is great, but more is better, certainly.
Yeah, but that's still that's an individual vaccine number, not a complete series, I don't think.
Right. Sorry, first at least one. Right.
Yeah. Yeah. I mean, and I think that's great. We still want to make sure that we go for full vaccination for everyone, because Delta is a formidable opponent. So.
Yes. All right. Anyone else? Questions? Binex card expiration dates keep receiving extensions. Are there any concerns? Are these still reliable with the Delta variant?
I don't think there are concerns, and I do believe that they are still reliable with the Delta variant. I think that, as always, they're antigen tests, and they're not quite as sensitive as the PCR. So we're still doing a lot of PCR, and if there's ever a concern, you can always flip to a PCR quickly and validate. But no, I think, like a lot of things, if you think about diagnostic testing, when things are first released, there really isn't a very complete knowledge of what the length that a test will be accurate and when it might outdate. These were originally released last fall and were said to outdate, or January 1st was the date, or 3 months after that really was what was looked at, but it was not based on a lot of experience and knowledge. And so as we go along, there's been increasing understanding. It's not all that different than I think when Lisa said with the vaccines. Again, a different question, but the same concept, which is how long is the shelf life? The FDA starts out very conservative on all of these, and then it moves forward as it gets more information.
I have a question from Chris about J&J. What's happened? FQHCs can no longer order it. Is it still available in the U.S.?
Yes, it is, and we're actually going to be getting more into the state. I'm not sure what the production and distribution difficulty were, but that I just heard, I think I think it was probably yesterday, that we will be getting some more J&J. When I say I don't know exactly how much, but it should be enough to provide for some of the places that have been routinely using it.
Yeah, and I think I recall hearing Tanya say yesterday that, it was definitely a production issue with that plant, but the new plant is scheduled to go online soon, and so they're expecting an influx. Then one more question here. Do we know what's the latest about reliability of so-called natural immunity after having had the virus? Seems like running into a lot of people who say they don't need the vaccine because they've had COVID.
Yeah, generally, the best guidance is that you've got really pretty good immunity up to 90 days after having had natural disease. And it's still recommended that people with natural disease get vaccinated. And as I said, they're okay for 90 days. So, on a flip side, when we're counting cases, if someone has had infection, we don't count, and they're test positive, we don't count that as a case because it may be just lingering viral particles, but until 90 days. After 90 days, we count that as a new case.
And is it not fair, Steve, to say that immune response varies considerably after natural infection? And
it does, and I think part of the problem is that what is the immune response that is specific enough to create neutralizing antibody and T-cell responses that will protect you from a new infection. And natural infection, unfortunately, doesn't appear to be as effective at doing that. And it's certainly it's variable depending upon the individual who had the infection.
all right. Anybody else? All right. Well, with that, thanks everybody for joining. We are still planning these right now, monthly on the second Tuesday of the month. Sorry, so that will be the Tuesday, September 14th. We'll be back again. We do post still the slides and recordings to the CDC website. Let's see, one more question here. 1 minute here. Although we're looking at T-cell response benefit, have we seen specific data around the durability with titers for antibodies?
I haven't seen anything that doesn't look at, when we're really looking at durability. So when you see studies like either Moderna or Pfizer or others that are looking at the immune response at 12 months, for instance, it tends to be looking at the entire immune response. So there may be some studies out there, I just haven't seen them, that would really say this titer is associated with this amount of immunity, which would be nice, but I haven't seen it.
And still, we often remind folks, the US CDC recommendation is that because we don't know the significance of antibody titers, it is not routinely recommended. I mean, we get a lot of questions about that. Check the titer, it's low. Don't they need another round of vaccine? But again, we noted at the beginning, probably not everybody was on, that the ACIP is meeting again this week, and they're going to make some recommendation about the benefit of a third vaccine or not in immunosuppressed, but there's still no standard recommendation. I believe that has not changed, correct, Steve, to check antibody titers?
Correct. So we just don't know how to interpret it. As to exactly that question.
Feel like you have to do something, right, if you check it. So.
Yeah.
All right. Okay. Well, we're at the end of the 30 minutes. So thanks everybody for joining. Thanks, Steve and Amy, for your contributions, and good luck, everyone, getting those vaccines out. We'll see you next time. Thank you. Bye-bye.